Today we will discuss about pain. So pain is one of the most important and most complex phenomena which every good clinician must understand in order to become a successful healthcare provider. It is a complex topic and we will be discussing it under following headings. That is introduction, then pain transmission. Under pain transmission, we will discuss about the receptors for pain sensation, the pain mediators, then type of fibers which transmit the pain, different components of pain, pain pathway, and the central connections. Then we will discuss about pain perception, which I will explain in terms of biopsychosocial model of pain. Then finally, we will discuss about pain modulation by means of pain gating and central analgesia. Now let's begin with introduction. One of the most common reasons any individual seeks the advice of a clinician is because he or she is in pain. So how will you define the pain? Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Now let's understand this definition first. According to this definition, pain is an unpleasant sensory and emotional experience. So it is important to understand that pain is not just a sensation. It has a powerful emotional component attached with it. I will discuss about emotional component in more detail while discussing about pain pathway. Then if we read the definition further, it says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It means pain may occur in the absence of actual tissue damage. Sometimes patients come to us saying, I have pain here or I am having pain there, etc., etc. But when we examine them, sometimes we don't find anything relevant. Traditionally, doctors used to label this kind of pain as psychogenic pain or non-organic pain. But research now shows that chronic pain in the absence of peripheral tissue damage has a physiological basis, and it is not merely a psychological manifestation. This I will explain in detail while discussing about pain pathway and its central connections. Now with above concepts clear in your mind, let me ask you one question. What do you think about pain? Is it a gift or a curse for the mankind? My answer is that it is a valuable gift by the nature. Why? Why am I saying it is a gift even though pain is very, very unpleasant? You will get your answer if you ask this question to those people who have lost their pain sensation and don't feel anything even if they burn or cut their finger or hand. At this point, let me mention about a rare congenital condition in which the person don't feel pain due to an inborn abnormality of nervous system. This is known as congenital insensitivity of pain or congenital analgesia. It is common for the people with this condition to die in childhood due to injuries or illnesses which are going unnoticed. Burn injuries are among the more common injuries. But this valuable gift will be like a curse if it becomes chronic, which in this case don't really serve any useful purpose, and rather it makes the person more and more miserable. Now the pain, it has three dimensions. They are sensory discriminative, motivational affective, and cognitive evaluative. The sensory discriminative dimension of pain refers to the sensation of pain and includes the location of pain, its quality, example whether it is burning or dull or sharp, etc. Then its intensity and the duration. The motivational affective dimension refers to the unpleasantness of pain or how much the pain bothers the person. For example, whether it is nauseating or sickening, etc. Then the cognitive evaluative dimension, it puts the pain in terms of past experiences and probability of outcome, and can as such modify both the sensory discriminative and the motivational affective dimensions. This cognitive dimension can thus negatively or positively affect the outcome, and it is based on the patient's belief. These beliefs may be their culture, their past experiences, etc. For example, imagine a person experienced a displaced fracture and it got malunited with resultant persistent pain and stiffness. Next time, if the same person gets just a hairline fracture, he will be more worried because of previous bad experience, which in turn leads to more and more pain. Now let's discuss about some terminology related to pain. So first is hyperalgesia. It is an increased sensitivity to a noxious stimulus, and it can occur both at the site of injury and outside the site of injury. If it occurs at the site of injury, we call it primary hyperalgesia. And if it occurs outside the site of injury, we call it secondary hyperalgesia. Next is allodynia. It is a term used to describe pain from a non-nociceptive stimulus. Then coming to referred pain, it is the spontaneous pain perceived outside the area of injury. Then neurogenic pain, it is the pain initiated or caused by a primary lesion, dysfunction, or transitory perturbation in the peripheral or central nervous system. Then coming to neuropathic pain, it is the pain arising as a direct consequence of lesion or disease affecting the somatosensory system. Next is nociceptive pain. It is the pain arising from activation of nociceptors. Then peripheral sensitization. It is the increased responsiveness and reduced threshold of nociceptors to stimulation of their receptive fields. And finally, central sensitization. It is the increased responsiveness of nociceptive neurons in the central nervous system to their normal or subthreshold afferent input. Now let's come to classification of pain. So pain can be classified as acute, persistent, and chronic. Acute pain typically has a sudden onset and recedes during the healing process. It can be regarded as a good pain, as it serves an important protective mechanism. Then the persistent pain, it characterizes many clinical conditions and is usually the reason that patient seeks medical attention. And finally, the chronic pain. This one is very bad. It appears to have no useful purpose, and it only makes the patients miserable. It can be considered bad pain because it persists long after the recovery from an injury and is often refractory to common analgesic agents. Pain is considered as chronic if it persists beyond 3 to 6 months. Another way of classifying the pain is superficial and deep pain. Superficial pain usually cutaneous in origin, whereas the deep pain, it originates from viscera. So that's all about introduction of pain. Now let's discuss about pain transmission. So pain is perceived by an individual when painful stimuli are translated into electrical depolarizations in free nerve endings, also known as nociceptors or pain receptors, which are then transmitted to central nervous system in the form of action potentials via the pain pathway. So first we will start with receptors. So the receptors for the pain, they are also called as nociceptors. They are the free nerve endings of primary sensory neurons. There are 4 classes of nociceptors. They are thermal, mechanical, polymodal, and silent. Each of these nociceptors are activated by different stimuli. Thermal nociceptors, they are activated by extremes of temperatures, like more than 45 degrees centigrade or less than 5 degrees centigrade. And they transmit the impulses via thinly myelinated A delta fibers. Whereas the mechanical nociceptors, they are activated by intense pressure, and they also transmit the impulses via thinly myelinated A delta fibers. Then coming to polymodal nociceptors, they are activated by high intensity mechanical, chemical, or thermal stimuli, and they transmit the impulses via unmyelinated C fibers. Finally, the silent nociceptors, they are found in viscera, and they are not normally activated by noxious stimuli. Instead, inflammation and various chemical agents, they dramatically reduce their firing threshold, and their activation is thought to contribute to the emergence of secondary hyperalgesia and central sensitization. These are the 2 prominent pain syndromes which we will discuss later on. Now coming to pain mediators, these are the substances which help in pain transmission. Pain mediators can be grouped into 2 categories. One group directly activates the nociceptors, whereas another group sensitizes them so that their firing threshold is reduced and thereby makes them more sensitive to noxious stimuli. There are numerous pain mediators, but few important ones. They are histamine, bradykinin, 5-hydroxytryptamine, also known as serotonin, then prostaglandin, potassium. Our cells, they are bags of potassium. So whenever there is an injury, these cells, they rupture and the potassium is released. Then another pain mediators include substance P, CGRP, or calcitonin gene related peptide, then acids, glutamate, etc. Now once the receptors are activated, the action potentials are transmitted via A delta and C fibers. Here let's briefly discuss about different types of nerve fibers in human body. So mammalian nerve fibers, they are divided into A, B and C groups, and the A group can be subdivided into alpha, beta, gamma and delta fibers. Now let's discuss very briefly about each of these categories. So first start with A alpha fibers. These are myelinated and they carry proprioceptive and somatic motor impulses and having fiber diameter of 12 to 20 micrometers and conduction velocity 70 to 120 meters per second. Then coming to A beta fibers, they are also myelinated and they carry touch and pressure impulses and having the fiber diameter of 5 to 12 micrometers and conduction velocity 30 to 70 meters per second. Now A gamma fibers, they are also myelinated and they are motor to muscle spindles and having fiber diameter of 3 to 6 micrometers and conduction velocity approximately 15 to 30 meters per second. Next is A delta fibers. They are thinly myelinated and carry pain and temperature sensation, and having fiber diameter of 2 to 5 micrometers and conduction velocity 12 to 30 meters per second. Next are type B fibers, which are myelinated preganglionic autonomic fibers with fiber diameter of less than 3 micrometers and conduction velocity 3 to 15 meters per second. Finally, the type C fibers. These are unmyelinated fibers. Some of them carry pain and temperature sensation and having fiber diameter of 0.4 to 1.2 micrometers and conduction velocity 0.5 to 2 meters per second. And some of the type C fibers, they carry sympathetic impulses and they are postganglionic sympathetic with fiber diameter of 0.3 to 1.3 micrometers and conduction velocity 0.7 to 2.3 meters per second. Now let's discuss about components of pain. Pain is having fast component and slow component. We simply call it fast pain and slow pain respectively. Imagine a hammer hitting your thumb. As soon as the hammer hits your thumb, you initially feel a sharp pain. This is called first pain or fast pain, which is followed by more prolonged aching and dull type of pain. This is the second pain or slow pain. The fast, sharp pain is transmitted by A delta fibers that carry information from damaged thermal and mechanical nociceptors, whereas the slow, dull pain is transmitted by C fibers that convey signals from polymodal nociceptors. Fast pain, it is also called as epicritic pain, whereas slow pain, it is also known as protopathic pain. Mechanical or thermal stimuli like pinprick or heat acts as the stimulus for fast pain, whereas tissue damage is the stimulus for slow pain. Then fast pain, it is sharp, pricking, burning and dermatomal, whereas slow pain, it is slow, dull, crawling and sclerotomal. Fast pain is carried by A delta fibers and they conduct it at the rate of 12 to 30 meters per second, whereas C fibers conduct slow pain at the rate of 0.5 to 2 meters per second. Now, receptors for fast pain, they are mainly distributed over the body surface, whereas receptors for slow pain, they are distributed everywhere in the body except central nervous system. Then fast pain stimulus, it causes reflex withdrawal. For example, if you touch a hot surface, you will immediately withdraw your hand to avoid the tissue damage. Whereas slow pain stimulus, it causes reflex muscle spasm. For example, imagine if you get neck sprain, it results in stiff neck due to severe muscle spasm and is associated with slow, dull pain. Here the main function of spasm is to enforce rest to the injured tissue. Next, the strong analgesics including morphine, etc., they don't help much in relieving the fast pain, whereas slow pain can be relieved by medications. Then fast pain, it reaches the thalamus and cortex and hence don't have any added emotional or autonomic signs, whereas slow pain along with thalamus and cortex, it also stimulates limbic system and hypothalamus and thus having strong emotional and autonomic components associated with this type of pain. So today let's stop here. Remaining part of pain transmission including pain pathway, its central connections and the pain modulation we will discuss in next video. So keep watching and don't miss my upcoming video. Thank you. Have a nice day.